So now I'd like to introduce the second of our NRO sessions, which is Complex Regional Pain Syndrome. And I'd like to introduce Dr. Philip Getson. He is Assistant Professor at Drexel University College of Medicine in the Department of Neurology.
Is this okay? Too loud? Too soft? It's good? I'm not going to stand up there because I'm a walker. I'm not a stander, so I apologize or don't apologize. My name, as she said, is Philip Getson. I'm actually a board-certified family physician who got appointed to the Department of Neurology in Philadelphia at Hahnemann because of my work in complex regional pain syndrome, or as I used to call it, reflex sympathetic dystrophy. And I have an impossible task today, which is to try and talk to you about this disease in an hour. It's, for me, an impossibility, but I'm going to do the best I can. And what I'm going to do, unlike what Dr. Argoff did just before me, is I'm going to talk more about personal experience and things that I'm seeing, because the disease entity is such that you can go to the books and you can look up edema and you can look up motor dysfunction and you can look up excessive swelling and hair growth and nail growth and temperature change. You can look up all that. What I'm hoping to tell you today is what you can't find in the books, or what you might have to look very hard to find in the books. I started out doing this in the mid-1990s, this being the evaluation and treatment of patients with reflex sympathetic dystrophy. And 13 years and 800 patients with this disease later, I now get invited to talk to you. So I want to begin this way. Life is infinitely stranger than anything that the mind of man can create. There's a quote from Arthur Conan Doyle, Sherlock Holmes. And being a Sherlock Holmes freak, I thought I would start with that because it brings me to the following. If you subscribe to that theory, life is infinitely stranger than anything the mind of man can create, I ask you the following. A patient in her 50s comes into the office. She is perfectly normal. She has no diabetes, hypertension, heart disease. She has osteoarthritic knees. And she goes to the rheumatologist, who's been in practice 30 years, and he sticks a needle in her knee, giving her Synvisc, not once, not twice, but on the third time, he manages to put the needle in such a place that the leg jerks out like she was hit with a percussion hammer. And within a month, she has symptoms of reflex sympathetic dystrophy, and within a year, she has symptoms of full-body disease. How does that happen? A patient comes into the office who is working as a veterinary tech, and she's bit by a dog in her thumb, and they treat the bite, and the well-meaning hand surgeon decides that he has to transpose a nerve to make it heal, and within 6 months she has reflex sympathetic dystrophy. A young woman falls off a bicycle and fractures her cheekbone, and the surgeon, meaning well and inadvertently, puts a screw in her trigeminal nerve, and she has reflex sympathetic dystrophy. And a young woman is sitting working diligently on her desk when someone opens up a drawer to the file cabinet, and it being top heavy, the entirety of the file cabinet falls on her back. It breaks nothing. She has a minor contusion. It leaves her some months later with a neuroma, which leads her to have reflex sympathetic dystrophy. The point of all this, of course, is that you never know where it's going to come from. It's really easy for someone to fall down and land on their wrist and break their wrist and impact on the brachial plexus, and we'll talk about brachial plexus in a minute. Those are really common things that you see, and I've given you 4 examples of things that are not as common. And I could stand here for another half hour and tell you stories about cases where we saw reflex sympathetic dystrophy that came from really atypical sources. And so the point is that you really need to look at a patient and ask the questions before you ever get to the remainder of the physical examination. The Reflex Sympathetic Dystrophy Association of America in Milford, Connecticut estimates that an RSD patient goes to 4.3 doctors before a diagnosis is made. Why is that? Now, Dr. Argoff talked earlier about WNL. We never looked. Okay. The fact of the matter is, if you don't know what you're looking at and for, then you really don't know what you're seeing. With apologies to anyone who heard me tell this story last year, I have a brief story to tell you before I begin with the slides. A little boy in Juarez, Mexico, approaches the border from Mexico to Texas on a bicycle with sandbags. The border police ask him what are in the sandbags, and he says sand. Okay, they look, and in fact there's sand. Well, they don't believe him. He's coming from Mexico to the United States. He must be bringing something else. And so they check, and in fact there are sand in the saddlebags of his bicycle, and they let him pass. 1 week later, the incident is repeated. What's in the saddlebags? Sand. And now they really don't believe him, so they x-ray the bike. Nothing there. Week after week, chemical analysis of the sand, strip search, anything possible, and they never find anything. This goes on for 6 months. Week after week, bicycle, saddlebags, sand. And then it stops. 6 more months pass, and one of the border guards is sitting in a canteen in Mexico. The little boy walks in. His curiosity being piqued, he walks over to the little boy and says, I don't know if you remember me, but I was one of the border guards. You're not in any trouble. I'm off duty. I know you were smuggling something across the border. What were you smuggling? And the little boy looks at him and he goes, bicycles. Well, you know, it's funny, but it's true. And the fact of the matter is that when you look at patients that clearly have sympathetic dysfunction and the history is right, then from my perspective, that person has at least sympathetic dysfunction, if not complex regional pain syndrome, and you need to approach it. And my goal here today, and my goal all around at this point in time in the lectures that I give, is to try and educate physicians and nurses and anybody, families, patients. If you know what it is, you have 2 jobs. Treat it or send it to somebody who can treat it. That's actually the only 2 jobs you have in medicine. I don't care what you do. You're a neurologist, you're a cardiologist, you're a dermatologist, you're in family practice. Treat it because you know how, or send it to somebody who can. So I have nothing to disclose, and learning objectives are what they are. And what I decided to do today was to go through the alphabet. Now, obviously I could go on and on and on and on, but I took a couple of representative things that I wanted to talk to you about that you may or may not see, alphabetically, just to make it a little bit more interesting for anybody who's listened to an RSD lecture before. And there I go again, I'm supposed to call it CRPS. The real A is atypical, because there really is no such thing as a typical RSD patient. When I went to medical school, which seems like half a life ago because it was, they told me that the typical gallbladder patient was a fat, fertile 40 female. 35 years later, and probably 50 gallbladder patients later, I've seen 1 fat, fertile 40 female that had gallbladder disease. So there is no such thing as a typical CRPS, I did it right, CRPS patient. Everybody's atypical because no 2 people are alike. I very rarely get anybody that fits the constellation. So A really should have said atypical. And you heard earlier today about allodynia, know what it is. But let's talk about arrhythmias. I have 4 patients, all female, who have pacemakers. Not one of them has heart disease. All 4 of them have a bradycardic response from sympathetic dysfunction. Now, make no mistake about it, cardiologists are not going to put a pacemaker into somebody without giving them the soup to nuts workup. None of these people have any intrinsic heart disease, and all 4 have pacemakers. One woman dropped down to 28 beats a minute, and she has a pacemaker, all the result of their reflex sympathetic dystrophy. Tachycardia, on the other hand, is really more common in young people with reflex sympathetic dystrophy. And the tachycardia can go 150, 160 to the point that it becomes debilitating. So there is absolutely a cardiac response because sympathetic nerve fibers are what they are, and they really innervate and affect the entirety of the body. I have a patient who is now 59 years old, who many, many years ago, maybe 8 or 10 years ago, had a massive heart attack. And I walked in and I looked at him and I said, I have some good news and I have some bad news, because he already had the reflex sympathetic dystrophy. And he said, what? I said, well, you know, you had this massive heart attack, and the bad news is, well, no, I take it back. The good news is we also found out that you have 3 blocked arteries and you're going to need at least triple and maybe quadruple bypass. And he looked at me and he said, that's the good news? And I said, that's the good news, because we're going to fix your heart. We're going to make your RSD worse. And we did. We opened up his chest. He's alive 10 years later. He's fine from a cardiac point of view. He's a mess from a CRPS point of view, because what it did, and when we cracked his chest, was we spread his RSD. And there really was nothing we could do about it. In order to save his life, this was the choice that we made. And I can't, at this juncture, get his RSD any better. And so I saved this man's life to spend the rest of his life sitting at home, because he's non-functional from his RSD CRPS. And he's alive. So I'm not sure how much of a favor that I did him, but I did it anyhow. Triple phase bone scans are a test that I do not do. And I'm going to tell you why I don't do that. Because as the statistic says, about 10% of all the ones that I've seen turn up positive. I'm not going to give somebody a radionuclide dye and radiate them for a test that's likely to give me a 10% positive answer. But more than that, the insurance company, you all know about insurance companies, the insurance company says, if the bone scan's normal, then they must not have RSD, therefore we don't have to pay the bills. And I'm not going to put a bullet in the gun of the insurance company. And you will hear that happen later on again and again, because if I can't get a positive yield with a high probability, why do the test? So while you will read statistics that say triple phase bone scans do this, that, and the next thing, I pretty much found them to be worthless in in the 800 patients over 13 years that I talked about earlier. Brachial plexus injuries are really the most common injury that I see, and the reason that this happens, at least I think the reason this happens, is because an individual falls down, and he or she will do what everybody does. When you fall, you put your arm out to protect your face. It's human nature. Okay, and so you break your wrist, and the orthopedic surgeons, who are some of my favorite folks, my son-in-law's an orthopedic surgeon, will treat the wrist fracture and ignore the shoulder impact injury and the brachial plexus injury. And what happens is that time passes, and they begin to develop symptoms of a brachial plexopathy, which then becomes a brachial plexus reflex sympathetic dystrophy. And the wrist is fine, thank you. I mean, it's fine, and the orthopedic surgeon has done what he or she is supposed to do. And as Dr. Argos said earlier, the EMG and nerve conduction studies are almost always normal. And so you have this conundrum, what do you do because you have a normal EMG and nerve conduction study and you know they got a brachial plexus injury? Well, first of all, you don't do the EMG because it's painful, it's barbaric, and it doesn't work anyhow. It's a motor function test and a sensory abnormality. And later I will tell you what I do. I don't do skin biopsies, as he mentioned. But what you do is, if you have to do the EMG, you bet somebody a large amount of money that the EMG will come back positive and show carpal tunnel syndrome, which they don't have because the test always does. It's a neat way to make a few extra bucks. Because if I do an EMG on a patient with a brachial plexopathy, he or she's going to come back positive for carpal tunnel syndrome. They have no symptoms. And there's a new thing out in I'm from New Jersey, which I actually am admitting. I'm from New Jersey, and surgeons in New Jersey are doing carpal tunnel surgery without EMGs now, which to me is a little bit frightening, especially since a lot of these people don't have carpal tunnel syndrome. Okay, CRPS is what we're calling it. I'll try and be good and do that. CRPS type 1 is the old reflex sympathetic dystrophy. CRPS 2 is causalgia. This last one that almost nobody's ever seen, CRPS NOS, is in the RSD literature. It's in the RSD Association's literature. I've never used the term. And the problem with the term CRPS 1 and CRPS 2 is that in 800 people, I think there have been maybe 3 that I've seen that you can't diligently track back to some nerve injury. So CRPS 1 really is almost non-existent in my world because almost everybody has some form of nerve injury if you allow the latitude of injury that I do, which is, for example, if someone does a venipuncture and instead of hitting the vein actually hits a nerve, well, that's a nerve injury. But it may not be a stress injury or a cut injury or any of the other, but still an injury. It's an impact injury. So we get hung up in terminology, and I believe that the people that come up with terminology do it to justify their existence. I wrote a paper to a letter to an editor once on the American Family Physician about a doctor who said, how can we call this reflex sympathetic dystrophy before the terminology changed? And he said, it's not reflexive, it's not sympathetic, and it's not dystrophy. And so I wrote this letter saying, who cares? I mean, really, who cares what you call it? It is what it is. Shakespeare said a rose by any other name would smell as sweet. Better than that, George Carlin said, how come we drive on a parkway and park in a driveway? Okay? And it's true. What difference does it make what you call it? The bottom line is you will hear me try and interchange them because I'm trying to segue to the term CRPS because that's what I'm told I'm supposed to do. But more often than not, I flop back to the term RSD. Dystonia is this. It is a very common finding, but not nearly so common as the RSD folk would have you believe. And you can have dystonia as the only symptom that you have. I had a patient sent to me a couple of weeks ago, which was the most horrific case that I ever saw of medical negligence and malpractice, of a guy who injured his hand. The hand became dystonic. Nobody seemed to know what to do with him. He clearly, in hindsight, I'm real smart on Monday because I know what happened on Sunday, but I look back and he clearly had RSD, and the surgeon decided that he was going to fix this kid's hand. So he took him to the operating room, he put him to sleep, and he put pins in each one of his fingers to straighten out his hand. Which, of course, did nothing but make his RSD worse. When they took the pins out, his hand went back into the dystonic state, and he's now just a full-blown disaster. I mean, he's really a non-fixable disaster. And the lawyer said to me, well, do you think in this case where the record's this big, anybody committed malpractice? I said, the better question is, did anybody not? Because person after person after person missed it, but the guy that put the pins in his fingers, I would like to take to the operating room with pins in his fingers. So they didn't hire me to testify in court because I think they were afraid that I was going to say that on the witness stand, and that probably would not have played very well. Okay, so we talk about diagnostic testing, and the reason, well, better question is this: why do we do diagnostic testing? In the old days, when I started 30-some years ago, we did diagnostic testing for two reasons. One, because we wanted to confirm a suspected diagnosis. Did the patient break his arm? Let's get an x-ray. Does the patient have a herniated, lumbar disc? Let's get an MRI. Or because we were trying to monitor something. I know this patient is diabetic. I need to know what his or her blood sugar is. Okay? That's the two reasons for doing diagnostic testing up until about 1990-something, when the third reason came about, which is because we have to prove to the insurance company why we're treating this patient. So we now do diagnostic testing for a wrong reason, because we know what's wrong with somebody. Okay? But we have to be able to demonstrate what lawyers call demonstrative evidence of injury or objective medical evidence. And so these are the tests that one might undergo, save for one which I have actually there's two, quantitative sensory testing, which Dr. Argoff mentioned earlier, which is not done by very many people in very many places. But these are part of the workup that you do for a patient that has pain and a problem. So that's what, there's another one that I will show you in a little bit. Okay, edema we all know about. I find that edema does not often respond to diuretics. People will come in, my feet are all swollen up, give me some Lasix. No. Why? It's not going to work. Well, give it to me anyhow. Okay, and then I'm going to treat your hypokalemia. We're going to give a little potassium, and then we're going to do this. And then you're going to call me at night and tell me you have leg cramps. So I try not to do it. Occasionally, someone will have a flare of the disease that will respond to diuretics. There's somebody who's fairly quiescent, doing fairly well, and then for whatever reason it just goes, like somebody set a match to it. That will respond to the diuretic short course. The second part of the E letter, the exercise, I get people moving from day one. Okay, if you can't walk, we'll find something for you to do. Because you must keep moving. Because if you stop moving, then the inflammatory component of this disease is going to get worse. And now I'm treating something that you didn't have when I walked in the door because you're stiff. So you've got to keep mobilizing people. Now this creates a problem. The problem that it creates is that if you want to send that patient to a physical therapist, you better find out what he or she knows about reflex sympathetic dystrophy. Because you would be amazed at the number of people who say to you, yeah, I had a couple of cases when I was in school. And so they begin stretching and they begin lifting people with brachial plexus arm over their heads, and now they're making a bad situation worse. So if you're going to exercise, do simple things that people can do without physical therapists. And if you need to send them to a physical therapist, then do it two things. Number one, do your due diligence about what that physical therapist knows about the disease. And secondly, what I do is I write a prescription that says, please evaluate physical therapy and send me a copy of your protocol before you start treating. Now, I'm not a physical therapist, but I know what I don't want done. And so I open up a dialogue. Okay, yeah, that's okay. No, that's not any good. And physical therapists hate me, but at the same time, at least I know we're not doing anything that hurts the patient. And then I educate the patient saying, if you're doing anything that causes pain, and I understand, you have to understand pain. There's the kind of pain that we get from shoveling snow when we haven't done it a while, and there's the kind of pain that we get where we know, hey, I'm waking up tomorrow morning in trouble. If it hurts, don't do it. People need to be a part of the program. Okay. So I alienate a few people. I do not believe that fibromyalgia is a freestanding disease. I believe that fibromyalgia is reflex sympathetic dystrophy. Thank God Dr. Ardoff is not in here because we would be having this debate. I do not believe that this exists as a separate entity. I think if you look at the books that describe the symptom complex of fibro, it's RSD. I never believed that fibromyalgia exists in the knee. I mean, clinically, if you read the how can it? And so the two papers that I gave you there are people who wrote papers saying, I don't think it's a disease either. I think it's part of RSD. So I don't have a lot of resources that I'm going to give you here because, as I said, it's really more important for you to get the hands-on stuff. But the next time you have a fibro patient, take in the back of your mind the consideration that maybe this is not truly what you old school thought was fibromyalgia, but rather what it is a manifestation of reflex sympathetic dystrophy. It makes sense. You can't tell you the number of people that came in. Have you had any medical problems? Well, yeah, I used to go to the doctor. They told me I had fibromyalgia. No, you didn't, but what you had then is what you have now, only it's worse. Because that motor vehicle accident flared up something that was already bad. It kicked a sleeping dog that was relatively quiescent. Family, if you're going to treat this disease, you've got to treat it as a family unit because it impacts on more than the patient. Worst case scenario I had is a woman who really is just a sweetheart of a woman, had neck surgery, had a redo of her neck surgery, had all kinds of problems with the complications of the neck surgery, had RSD independent of the neck surgery, and she would go home 6 weeks after the surgery was completed, and she'd walk into the house and do the things that she could do, which was very little, but she did the best she could do, and the husband would come home, and he'd run his hand along the thing and said, you didn't dust today, it's dirty. And so I told her to get a gun and shoot him, but she didn't. Because I figured the world would be a better place. But the fact of the matter is, if there's no cooperation on the other end, what you're doing is you're now adding a huge psychological component to the already bad physical/psychological component. Make no mistake about it, every patient with reflex sympathetic dystrophy is depressed. They may not be suffering from clinical depression, but they're all depressed. How can you not be depressed? You get up in the morning, you feel like crap. You spend the entire day feeling like crap, and you go to bed at night feeling like crap, knowing that you're going to get up tomorrow morning and feel like crap. So if you're not depressed, then you're insane. Because those are the only two options you have. Now, understand there's a difference between being depressed, which we all get it sometimes. Somebody dies, we lose the job, we need money that we don't have. That's being depressed. That's normal. And then there's clinical depression, which is an entirely separate entity. And a lot of these people fall into that clinical depression line. But everyone is depressed. So you need to get the family unit. If the kids are old enough, they have to understand. If the kids are young, you have to help them understand why mom can't take them to the playground and push them on a swing, if in fact that's the case. Because what you're doing is you're building in the family dynamic and everybody is working toward a common goal. Just by a show of hands, this first thing, how many people here that actually have seen patients with reflex sympathetic dystrophy have seen them have gastroenterologic symptoms? Good, more than I usually get. Nausea, vomiting, gastroparesis, absolutely. Constipation, flare of irritable bowel syndrome, all these things are real and happen. And the best treatment that I have found thus far for the gastroparesis is to have a gastroenterologist do an upper endoscopy and take some Botox and put it into the pyloric sphincter, and it relaxes the musculature and they stop throwing up. And it doesn't last forever, but it does work. You got to educate the gastroenterologist. Any gastroenterologists here? No, okay. We got to educate the gastroenterologist to doing this because mostly they have no idea. And I send people to GI folks because they have intractable vomiting and they do all these things and none of them work. And I say, well, when you've done all the things you're going to do, then put some Botox into their pyloric sphincter and they'll be okay and you'll call me. I've had two patients who we did everything we could possibly when we could not stop the vomiting. I got a woman who lost 60 pounds from throwing up and she couldn't leave the house because all she did was throw up. And she wound up having surgical revision. And the interesting thing is that I had two people that had surgical revision to stop the nausea and vomiting because of reflex sympathetic dystrophy. And if you talk about life being strange, they were sisters. They're the only two people that I couldn't stop the vomiting on without surgery, and they were sisters. And we'll talk about familial stuff in a minute, like right now. Genetics, forgot what letter of the alphabet I was doing. there is nothing in any of the literature that I can find in the world literature that talks about genetic predispositions to reflex sympathetic dystrophy, which makes it really hard for me because I have 18 families where more than one member has the disease. And someday, if I ever have time, I'll write the paper. And it's not just two sisters. It's mother and son, father and son. I have a family where father and two sons have the disease, and as bizarre as this sounds, one of the son's wives has the disease. Now, obviously, that's not genetics. And what I find is that when I get a member of the family that's diagnosed, they're going to tell me that there's somebody else out there, their sister, their twin sister, their half sister, their brother, who has the same symptom constellation. And oh yeah, by the way, they're not being treated for this. They're probably being treated for fibromyalgia. But they're being treated and they have it. And so I've collected this data where I've got 18 families. Now, if there's not a genetic predisposition, then how do I have 18 families? I mean, I'm one guy in America. I got 18 families. I mean, there has to be. And the stuff that happens is fascinating. I have two sisters 18 months apart. The first sister was involved in an incident in a casino in Atlantic City. A cart with money, back in the days when they actually used money in the casinos to pay people, a cart is being pushed and the guy actually loses the cart and it goes down a small incline and it impacts upon the side of her thigh. And she winds up with a crush injury to the nerve, which becomes reflex sympathetic dystrophy. And we treat her, and she does relatively well. And about a year and a half later, her sister, who's a police officer, gets broadsided by a car. And it turns out that the car causes the door to impact on the leg in the same place that she had the impact of the leg. And she winds up with a crush injury to the leg, which turns out to be reflex sympathetic dystrophy. So going back to the beginning, if you really don't believe that life is strange, you listen to these stories and you have to ask yourself, why is it not only do they have it in the same place before it spreads? Hoarseness. When I get people come into the office and I'll take the history and I'll say, do you find yourself getting up in the morning and you're hoarse and you're kind of raspy and you say, okay, I'm getting sick, but then it just goes away, and then later in the day it happens again, and maybe that happens 2-3 times a week or 2-3 times a month, and invariably people look at you with these giant eyes like, oh my God, how did he know that? That's not in the medical records. And I tell people, because it's what I do. This intermittent dysphonia is the result of an irritation of the branchial, not brachial, branchial plexus that causes people to be hoarse. And it's intermittent, and most times it just comes and goes. Sometimes it comes and stays, and literally you can't hear the people because they're so hoarse. I mean, sitting in close proximity in a treatment room, you can't hear them. And what we have found that works for that, believe it or not, is Botox into the vocal cords, which it doesn't last, but it does work. Headaches, people come in, I have migraines. No, you don't. Because what happens is you get behind them and you put some pressure on the greater occipital nerves, and then you peel them off the ceiling because the greater occipital nerves are so incredibly tender. And if you block the greater occipital nerves, which you can do in the office very easily, the headaches go away. If you can't block them, or for some reason they have more complex headaches, I have really found that butalbital, which is Furacet or Furanol, works. All the triptans don't seem to work. I don't know why. I've tried them all. Migranol doesn't work. Ergotamines don't work. The only thing that seems to work in oral form is butalbital. And then what happens is people begin to take too much butalbital, which means they're taking too much aspirin or Tylenol, and then you have a whole separate issue. So when I can, I block them. I have found, quite coincidentally, that blocking them with Novocaine and steroid works well. Blocking them with homeopathic agents works better. And I don't know why. I mean, I don't have any reason to tell you that this works better than that, but I have used homeopathic agents to do greater occipital nerve blocks, and I only do those blocks on my hardest, most difficult, contrary people, because I figure if it works for them, it's going to work for everybody. And I get people that nothing makes them happy. Hey, you took my headache away. So I begin to believe. So it's something to look into when people come in with the headaches associated with RSD. Hyperbaric oxygen, I am trying to convince hyperbaric oxygen suppliers to let me do a research study. There were 2 research studies in the entire world on hyperbaric oxygen. Everything else is anecdotal. One was written through the government, through the armed forces, which I immediately discounted, and the other was written in Europe and really is not terribly good. And I have reason to believe from anecdotal studies that hyperbaric oxygen will work with reflex sympathetic dystrophy. Now let me extend that out a little bit. When you get somebody that comes in a wheelchair, hyperbaric oxygen is not going to work. I have what I call an arena theory. This is mine, you won't see it anyplace. The arena theory is this. If you have an arena and you have someone in that confined arena, you can deal with them. Once they get outside that arena, they're gone. It's kind of like a horse in a corral. If the horse is out in the field, you got to go catch it. If it's in the corral, you got a chance of doing what you want to do. So if I can do what I have to do to get somebody into my arena, to bring the pain level down, to bring the sympathetic dysfunction down, to bring them into a place where I can do other things, then maybe all those other things like hyperbaric oxygen, like homeopathic agents, etc., are going to work. They're not going to work on a lady that comes in a wheelchair that's had RSD for 14 years. But we're trying to get funding to do this. Interstitial cystitis is almost always a neurogenic bladder in patients with reflex sympathetic dystrophy. Interstitial cystitis does exist. I'm not telling you it doesn't. But if I've got somebody that's got RSD and has bladder dysfunction where they're leaking urine, where they have urge incontinence, stress incontinence, difficulty voiding, any of those things that go along with interstitial cystitis, burning when they void, it's almost always a manifestation of the reflex sympathetic dystrophy. I've proven this by taking people and putting them in the hospital. One of the interventionalists put a needle in their back. They do epidurals for 5 days, and these people have completely normal bladder function after that for a period of time, because everything wears off. I've had patients with bladder pacemakers put in by the urologist to get them to stop doing that, because but I find that most patients with RSD that are diagnosed with interstitial cystitis actually have neurogenic bladders. I needed a J, so that's why, I needed a J and an X. The rest of them were easy. The movement disorder is really more that spastic jerking kind of thing, almost like getting hit by a percussion hammer. It's interesting to see how many spouses laugh when you ask them, does the patient jerk at night and, whack them in the face and knock them out of bed and things like that. And people actually wind up sleeping in separate rooms because of this. It's almost always worse at night. And baclofen and tizanidine work separately. The literature tells you not to use them together. Sometimes you have to use them together. But that's what those two drugs were created for. Baclofen, way back when, and tizanidine or Zanaflex more recently. People misuse tizanidine thinking that it's a muscle relaxant. It's not. It's an antispasmodic. And it's meant for the jerky movement. It is very sedating. You got to be really careful giving it to people during the day because they get real tired from it, and people don't like that feeling. But it works very well if you can titrate the dose, and it stops that jitters. It also sometimes stops that real fine Parkinsonian type hand tremor that people get as a consequence of the movement disorder of reflex sympathetic dystrophy. The patient that I have that has the worst hand tremor of all the people that I have with a hand tremor is by trade a hairstylist. And so we have a standing joke that she can't cut my hair because I'm not going to put a scissors or a razor in her hand because her hands go like this. But with the combination of drugs, she settled down to a mild fine tremor, but I still won't let her cut my hair. Okay. I could probably do an hour on ketamine alone. I don't know how many of you anybody used ketamine yet? Okay. So you understand that ketamine is, in our estimation, the latest, greatest treatment of reflex sympathetic dystrophy. Let me give you the 5-minute summary. In the late 1990s, an American physician by the name of Harbutt was in the country of Australia, and he was playing around with treatments for reflex sympathetic dystrophy with 2 Australian researchers whose name I don't remember. And they found that if you gave ketamine, which is the world's most potent NMDA inhibitor, to patients with reflex sympathetic dystrophy, their symptoms got better. And if you gave them more ketamine, their symptoms got more better, as my grandfather used to say. And if you gave them more ketamine, they got still better. And if you gave them more ketamine, they got psychotic. So there was a point at which they titrated it back, and they wrote a paper in 1999, which was the first paper written on ketamine for the use of reflex sympathetic dystrophy. Prior to that, ketamine was and still is to some degree an operating room anesthetic, and it is maintained in dentist offices. Oral surgeons use it a great deal. Emergencies use it for wound care, especially in kids. And it still is an anesthetic that is used on occasion, but mostly it has been supplanted by newer agents. Ketamine, given intravenously, works wonderfully well for the treatment of reflex sympathetic dystrophy. It does it through a mechanism that is postulated, and I'm not really sure necessarily known, but it works wonderfully well for people in the arena that I described a little while ago. And it's done in many fashions. There is a comatose dose of ketamine, which used to be done in Germany, but they shut down when there was a complicating factor of a woman who almost died over there, and they decided they had enough. It is done right now in Monterrey, Mexico, and it is going to be done, we think, in the Caribbean sometime within the next 12 months. And the comatose dose means that a patient goes to the site and they go into a drug-induced coma so that they can get enough ketamine to really blast away the RSD, for lack of a better term, while not making them psychotic. And they spend 4, 5, 6 days in a coma and they wake up, and the percentage of people that have come out of there symptom-free is about 60%. Symptom-free. Now, unfortunately, what we then learned was that when you bring them back to this country, you need to booster them. You need to maintain that ketamine at periodic levels, 3 months, 6 months, 9 months, indefinitely, to keep that ketamine in the system as a general rule, because if you don't, they begin to regress. And it's almost like Awakenings with Robin Williams and Robert De Niro, where when they stopped doing this, they went right back to where they were. So that's the comatose dose of ketamine. The awake ketamine is done in 2 fashions. It's done on an inpatient and outpatient basis. The difference being the quantity of the drug that's given. When I started doing ketamine in my office with Dr. Schwartzman and Hahnemann, which is 6 years ago, there were 3 of us in America doing that, he and I and Harbert, who I mentioned a little while ago. And at last count, there's some 55 sites in America now doing intravenous ketamine, because everybody sort of jumped on the ketamine bandwagon. There is much, much more to be said about ketamine than I'm doing here. Time does not allow that. I'd be more than happy to talk to any of you after we're done. I can give you links and websites and all kinds of things to do, but it is really a wonderful, wonderful drug. It has 2 side effects. One, it has cardiac side effects, so every one of the patients that has it needs cardiac clearance and cannot have any underlying heart disease. Number 2, it has psychotic type potential. It gives people nightmares, which most people are very glad to trade for being able to sleep. But you have to be careful of the underlying psychosis, and so everyone has a psychological evaluation, because as a general rule, the idea of somebody getting ketamine and jumping up out of the chair, ripping up all their clothes and running down the hall doesn't thrill me. So we have everybody cleared, and I have to tell you, having done over 100 people in my office, in the office itself, I've had exactly 2 complications, one of which had nothing to do with the ketamine, and the other one was in a guy who had a respiratory problem because he neglected to tell me that he had a respiratory problem, and we have him pulse oximetry monitored. Now, I found out just before I started the conversation that this young lady in the front row has had ketamine and started in a wheelchair and now is here. And she tells me in remission. So we just met, and I know no more of the study, but if anybody has specifics, I'm sure I'm volunteering you. I'm sure she'd be more than happy to tell you her story. Ketamine is a lecture unto itself, and I really don't want to sit on one thing, but there's a lot of information out there. There are 2 double-blinded studies done, one in Europe and one by Dr. Schwartzman at Hahnemann, where they have given ketamine and given placebo, and really proved in valuable studies beyond doubt of the value of ketamine. And it's not for everybody like anything else, but for people who are having refractory symptoms, people who are getting kind of avalanche and they're starting to get to the gate to get out of the arena, it really works well. I have to tell you that in my office I've got about 80 to 85% people better. Now, I have to explain better to you. Better means they have less pain and therefore take less drugs, or they have a much better quality of life and do much more, or both. My prize patient came in a wheelchair and last week asked me if it was okay if she took her grandkids bowling. She never took a narcotic, came in with this wonderful God-based attitude of being a reverent Christian and going to church and believing in God and spiritual and all this, and she came in a wheelchair with intractable vomiting. We could not get her through a session without her getting up 3, 4, 5 times and going to throw up. She's not thrown up now in 11 months at all. Okay, she's working part-time. She has no assistive device. She walked into my office with her 2 grandkids and asked me if it was okay if she took them bowling. I told her rollerblading was out, but bowling was okay. Lidocaine, which as you all know is a topical anesthetic, is also used intravenously in a few people with very good results. Yes? That's okay.
But considering ketamine's relatively short half-life, how does it
The question is, since ketamine has a relatively short half-life, how does it stay? And the answer is it gets absorbed into the system in these people, it gets to the brain as best we can postulate, and it stays. And people get how often are your boosters?
My boosters
Yeah.
are approximately every 3 months.
Every 3 months. Because really what it's doing is it's sort of, I'm not going to, it's stored in the NMDA. It's reversing the NMDA inhibition. I mean, it's inhibiting the NMDA sites, and the body's actually auto-correcting, is my own theory. You know, the body's doing what it's intended to do. It's fixing itself. Okay, and then it kind of runs out. I have people that come every 2 weeks. Some people come every 3 months, 6 months, 9 months. We don't know enough to know how or why. We just know that it does. But I understand what you're saying. The half-life is short, and yet she goes every 3 months and you get some and flies to Las Vegas and exhibits. So I wish we had answers. My best answer for you is I don't know. But at the same time, I'm real happy that I don't know, because it means I can keep on doing it. Lidocaine is used intravenously in intensive care units. Some people respond very, very well to intravenous lidocaine. The topical patches are what they are. But the intravenous lidocaine works to correct RSD. Again, most times it doesn't hold and has to be repeated, usually at about 6 month to 1 year intervals. But for people that have refractory pain, not a bad way to go. Okay, I am not going to go through this whole list. I am going to tell you just about 2 of them. Mexilatine is oral lidocaine. If you're not familiar with it, it works anecdotally in some cases. The bottom 2 there, dextromethorphan, as you know, is the DM in Robitussin DM, and amantadine is a influenza drug. Amantadine has no side effects. So it's covered on prescription plans, so it's certainly worth trying. I really have no idea, again, why it works. It works in some people, and a drug that has no side effects is certainly worth trying. And the rest of the stuff you've seen, I am not a big proponent of antidepressants. Elavil and amitriptyline and all those kind of things put weight on women, and I have found that if you walk in and say, here, this drug may help your pain, but you're going to gain 25 pounds, they hand you the prescription back. So I don't even do it anymore. Neuromas cause a tremendous amount of RSD, especially Morton's neuromas. Cryosurgery on Morton's neuromas seems to work. You got to be real careful, but there are people that you can cryo the neuroma, which is the inciting source of the reflex sympathetic dystrophy, and in doing so, you can actually make people better by getting rid of the underlying cause. Intra-pelvic neuromas, which I had not heard of until about 7 or 8 years ago, are devastatingly painful. And difficult, because you've really got to go in, you've got to do a laparotomy as opposed to a laparoscopy and try and get the neuroma out. And that's really, really a problem. Let me step aside a second. There is a paper that is in for release and publication that Dr. Schwartzman and I did, which discusses the use of intravenous ketamine intraoperatively. Okay, there is no paper on the market today that talks about this. There was, again, one anecdotal report from Europe. My portion of the study was 20 people. His was about the same number. In my 20 patients who had everything from dental surgery to podiatric surgery and everything in between, not one patient extended the reflex sympathetic dystrophy. Intraoperative ketamine in a dose of 80 to 125 milligrams effectively seems to block the spread of the disease. Knee surgery, shoulder surgery, it doesn't seem to matter. Intraoperative ketamine, I'm hoping the paper will be accepted, not because I want to see my name in print, but because the information needs to get out there. Okay. Intraoperative ketamine, and so if a person needed a pelvic neuroma, they would have intraoperative ketamine, higher dose if they could tolerate it, about 125 milligrams intraoperatively to prevent that pelvic neuroma and the administration of it from spreading the disease. This last line, no other diagnosis better explains the symptoms, really should have been set down. It shouldn't be under neuroma. It's placed there. The RSD Association of America has 5 criteria that talk about edema and sweating and so on and so forth. But the one that they added a couple of years ago was no other diagnosis better explains the symptoms. If you know what it isn't, and the symptom criteria fits, then it's reflex sympathetic dystrophy. It's knowing what is not. And that's where that fits in. And to me, that really should be the first criteria and not the last. Otophobia, extreme sensitivity to noises, especially the bass. I mean, people will tell me they're riding in a car and a kid next to them has a bass cranked up, and it literally increases their pain. Okay, photophobia, which should be there but isn't there, is another thing. Extreme sensitivity to light, another real problem for patients with this disease. In my estimation, there are 4 pains of reflex sympathetic dystrophy. There's muscle pain, which we all understand. There's inflammatory pain, which we all understand. Okay, no problem with either one of them. The deep bone pain is really a descriptive term that I hear in people with. I get somebody jabbed a screwdriver into my thigh. And that's the way it gets described to me. That deep bone pain is clearly the pain that you have to treat with pain medicine, because it's not going to respond to anything else. You can get rid of muscle pain with muscle relaxants, steroids, non-steroidals, and neuroleptics for the burning pain, and there's a whole bunch of them. But I ask my patients when they get pain to sit down and quantify the pain. Tell me what this pain is. Describe it for me. I want to know what kind of pain you have. Because if you've got this pain, I want to do this. If you have this pain, I want to do this. Because the theory is pain, and that's not true. I mean, God, we're PAINWeek. But pain is not all pain. Headache pain is not the same as deep bone pain, is not the same as burning pain, is not the same as muscle pain. And everybody wants something for pain. Well, okay, that's fine. I'm happy to give you something to treat the symptoms while we're trying to make you better. But let's give you the right drug. Let's give you the right key for the right lock. The psychology of this is clear. You've got to get people off the thinking that this is their disease. My RSD is a term we do not use in the office. Okay. I have reflex sympathetic dystrophy. I don't intend to let it take over my life. It's the mantra. Okay. My RSD is terrible. Nope. Start again. Nope, start again. I mean, I just don't let it happen, because when you take it in, Chinese medicine will tell you when you take things in and they become a part of you, it's what you're putting out there and what you're absorbing into you. You need to get rid of that thought. It is something that unfortunately you happen to have come across in your life, and you need to get rid of it. You're not going to get rid of it by adopting it as your own. Pregnancy, well, I have 11 patients. I really should just stop talking and write papers. I have 11 patients who got pregnant, and 10 of those 11 patients went into remission in the 3rd trimester of their pregnancy. 10 of 11. And 4 of the 11 breastfed and stayed in remission until they stopped breastfeeding. And none of the 11 got the RSD to come back to the level that it was prior to the pregnancy. Suggesting, of course, that there is some hormonal basis to what's going on. Again, it's still difficult to say to a mother whose 17-year-old daughter has RSD, send her out and get her pregnant, she'll be fine. Because I tried that once, and it really didn't work well at all. But the fact of the matter is, it's not anecdotal when you see this number of people. I had a girl who, and the reason I learned this was I had a patient who got pregnant at 15. And she was nasty bad with RSD. She'd go in the hospital for morphine infusions, and she was just horrible. And she got pregnant, and RSD went away about 4 months in. I mean, literally went away. I mean, this kid was doing everything at 4 months. And she was fine. And she stayed in remission until she was about 18, and the symptoms started to sort of creep back, and she got pregnant. And she swore to me that the second time was not intentional, but I never believed her. I truly didn't believe it. I think she did it because she wanted to get rid of the symptoms again, and she felt, well, if it worked once, it'll work again. And it did. And so she had a second child, and she stayed in remission, and then got married, and moved out of town, and got pregnant a 3rd time because she wanted to. Because she never had another RSD symptom. She's now 25, so she's 10 years after the first pregnancy, 4 years after the 3rd pregnancy, has no RSD symptoms, is in complete remission, gets no treatment, no boosters, no nothing. And the remission, followed the 2nd pregnancy, actually. But I've seen this over and over and over again. They get pregnant, and I sit back, which brings me to this story. I had a patient who was involved in a motor vehicle accident. She developed shoulder problems. The surgeon wanted to do shoulder surgery. I told him not to do the shoulder surgery. We argued. She got pregnant. He said, I can't do the surgery until she gets unpregnant. I said, it doesn't matter, because after she's done with her pregnancy, she's not going to have the shoulder pain anymore. Okay. She got into about 6 months of pregnancy. The shoulder pain from her brachial plexus injury, not from her intrinsic shoulder problem, as my friend, the orthopedic surgeon, thought went away. All her RSD symptoms went away. She had a healthy baby. Her RSD symptoms came back at about half. The shoulder problem never came back. She avoided surgery that she didn't need. So these are things that you just learn from going through and doing it. Those of you who heard Dr. Argoff earlier, he talks about quantitative sensory testing. It's really not used very, very often. It measures vibrational and temperature gradients in the body. It's relatively innocuous. If you can find a QST machine, it does really have a value. But again, there's not a lot of data, not a lot of studies, and not a lot of machines. The last line you've already heard me say, and this is just definition, and for time constraints will pass by. You know these terms, the abnormal sweating, the abnormal swelling. I want to talk to you about the spread of the disease. Dr. Schwartzman in Pain in January of 2001 wrote a paper. It's the only paper I could find talking about the spread of the disease. And 800 people that I've seen, I would bet you 725 of them have symptoms in more than one area. You hear this, RSD doesn't spread. Baloney. Baloney. And not only does it spread limb to limb, and by the way, 98% of the time it spreads either horizontally or vertically. It only spreads 2% of the time diagonally. It spreads to internal organs, as you heard me describe earlier. It spreads to every aspect of the body, and it spreads in almost everybody. And invariably, people will tell you that when it comes to the second site's worse than the first ever was. So the goals are functional restoration, pain management, psychological treatment, medical, psychological, familial, and all these different kinds of ways to treat pre-alt. The one fourth from the bottom is snail venom, which in the literature suggests that it works very well. I have never seen it work, which doesn't mean that it doesn't. It just means I've never seen it work. Some of the stuff at the bottom, surgical sympathectomies, not something in my world. Radiofrequency procedures work very, very well for people that have concomitant nerve lesions. They have a lumbar radicular problem because of a disc and reflex sympathetic dystrophy, so we're treating the underlying problem this way and the RSD the other way. Surgery is a necessity. You've got to fix a problem if you can. If somebody comes into the office and they have a herniated lumbar disc with nerve root compression, take them to the operating room and fix their disc. Because until you get rid of the pain generator, you're never going to get rid of the reflex sympathetic dystrophy. Fix the problem. If there's an identifiable entity, fix it. Now, you don't have to take a bunion away, but fix the identifiable underlying problem. Okay? Diet and lifestyle alterations cannot begin to tell you the effects of eating healthy, eating low inflammatory food, doing exercise, taking vitamins, Reiki. My wife is a Reiki master. We did a tremendous study. I'm going to talk to you in a minute about thermography. We took thermographic images of an individual that had RSD. She gave her a Reiki treatment. We took thermographic images. Next week we did the same thing. Next week we did the same thing. And over the course of 6 weeks, you could actually see her RSD symptoms going away thermographically. And the only thing we were doing was giving her Reiki and energy treatments. I have a patient who has MS and RSD, and you kind of wonder why anybody gets those two diseases together. And she is symptom-free because she's doing Ayurvedic medicine. Talked to her last week. She says, you probably wonder why I haven't seen you. That's what I'm doing. She said, I don't have any symptoms. I don't take any medicines. I don't have any symptoms. It's a part of the whole. Okay. So here's my point here, and to me, again, like I said, I could do an hour on ketamine. I could easily do an hour on thermography, and if you come next year, we probably will. This, to me, is the best diagnostic tool for sympathetic dysfunction. It is, in my estimation, 100% reliable. I've been doing this since 1982. I have never, 0 times, never seen it be wrong. Show of hands, anybody know what thermography is? Okay, not too many. Infrared imaging. Infrared imaging of the human body without contact, without radiation, without compression, without pain, without anything, and it works. And it looks like this. If you look at this, and most of you have never seen a thermogram before, I can tell you that the body is a symmetrical entity. If you look at the right arm on the left side and the left arm, they pretty much look at the same. This person appears to have 3 digits. And in point of fact, he actually has 5. But this hand is so dropped off cold, okay, because of the reflex sympathetic dystrophy, because of the sympathetic dysfunction, you get a picture that looks like this. Okay. Not only can you diagnose reflex sympathetic dystrophy in a cost-effective, in many cases covered by insurance fashion, okay, you do it quickly, simply, and easily. And if I had the time, as I do with my patients, I sit down, I go through the pictures, I show them this stuff, and it's amazing what happens when you tell somebody, I know what's wrong with you, here, look at this. Because now all of a sudden there's 4.3 doctors that were telling them all different things. There it is. somebody called this a picture of pain. It's not a picture of pain. It's a picture of the underlying disorder that's causing the pain. But this, in my estimation, is the best way to diagnose reflex sympathetic dystrophy. And for my money, the only way to diagnose reflex sympathetic dystrophy. Now, your CAT scans and your MRIs, etc., are necessary entities to make sure of what isn't. But when I have somebody come in and I go back to why we do diagnostic testing, we do it because of this, that, and the next thing, and we do it to keep the insurance industry happy, I have objective medical evidence of RSD. And in the state of New Jersey, this is a compensable medical test. I say this because if you'll allow me a 1-minute story, I started doing thermography in 1982. In 1984, Allstate and State Farm, the two biggest insurers in the United States, said they were not going to pay. I had a lawyer who was a multimillionaire. He didn't care. He took the case pro bono for me. And he said, we're going to sue Allstate and State Farm. I figured, heck, if you're going to sue somebody, you might as well go after Allstate and State Farm. And so we sued them, and we spent 7 weeks in trial in New Jersey, and we won. They said, that you've proved that this is a valid diagnostic test. So they appealed, and 2 years later we went to the appellate division, and we won. And 3 years later we went to the Supreme Court of the state of New Jersey. Now, for those of you who have ever seen the movie The Verdict with Paul Newman, you remember this kind of down on his luck alcoholic lawyer with battered briefcase and no resources, and I'm not an alcoholic, but anyhow, on the other side of the room was all that money. So we walk in to see the Supremes, and sit down here, me and my lawyer, and the other side we got Allstate's lawyers from Illinois and State Farm's lawyers from Illinois or Indiana, with their Zero Halliburton suitcases and their $10,000 suits in 1990, and it was James Mason in my mind all over again. And the Supremes walk in, all 5 of them, and they sit down, and the guy from Allstate stands up to say something, and one of the guys, the lead Supreme, who was not Diana Ross, says, sit down, okay, you're not going to talk. He said, we've already decided, they win, you lose, okay, see ya, okay. I mean, the whole proceeding took like 1.5 minutes. So in the state of New Jersey, in the law journals, there was a thing that says thermographic diagnostic imaging versus Allstate, State Farm, and the state of New Jersey, okay. And in New Jersey, this is a compensable medical test. There's what it looks like in a leg. I know we're running short on time, so let me just control the underlying causes, make sure that people don't have any other problems that you need to get rid of. I talked about visual disturbances such as blurring visions, and most ophthalmologists really have no idea what they're looking at, so you need to look for a neuro-ophthalmologist that will help you. Okay, vasomotor changes you've seen. One of my favorite slides from before. Okay, everybody's kind of looking. You know what it says? It says, work backwards. Okay? Because that's what you have to do sometimes. Because by the time you see an RSD case, they've been to 4.3 doctors, or at least 3.3, and you really need to go backwards and figure out and undo it and start this thing as if you were looking at time-lapse photography in reverse. X-ray, because I couldn't think of anything else that began with X. And xylophone didn't seem right. Yoga and meditation, and I talked to you before about relaxation and spirituality. And that one is up there because the number one complaint I get in my office, RSD or non-RSD, is I can't sleep. And boy, it's an issue. And it's an issue that I have not yet found an answer for. I've tried a lot of different things, naturally, non-naturally. Ketamine puts people to sleep while they're getting it, but it's a big issue. I don't have a conclusion like that, like others do. This is my conclusion because I started with Sherlock Holmes, so I'll end with Sherlock Holmes. When you eliminate the impossible, whatever remains, however improbable, must be the answer. It's sort of a credo for me as a Sherlock Holmes fanatic, because as strange as things were to begin, they seem impossible on the back end. But when you start putting all the pieces together, this is just part of life's medical mystery, and one that I find fascinating, which is why I'm standing here and talking to you. And I will be delighted afterwards, so I don't interrupt Dr. Argoff in his next lecture. We can stand outside. I have a website. I have phone numbers. Anybody emails me, I will call you back. If you call me, I will talk to you. But I crammed in here to an hour of stuff that really should have taken a lot longer. I thank you for coming. I appreciate your being here.